Perfect. All right. So I see the numbers coming in are slowing down, but still increasing. We're going to go ahead and get started. I want to thank everyone so much for taking time out of their busy schedule to join us this afternoon. This webinar has been in the planning for quite some time, and we are here and excited and ready to get going. So all about Part C, our infants and our toddlers, and the interagency partnerships that are needed to make sure that they get the services that are needed so that they can thrive. That's why we're all here. Our vision is that infants and toddlers with delays or disabilities receive high quality intervention services and supports as early as possible to empower them to thrive and meet their and their families' individualized needs. We know that research shows that IDEA Part C services can improve children's developmental outcomes, and the earlier infants and toddlers that are either have or at risk for disabilities are identified and served, the better the outcomes for the child, for the family, and for the systems that serve them. We know that there are groups of infants and toddlers, particularly infants and toddlers of color, those from low-income families, those in families whose primary language is something other than English, and those living in rural areas that are disproportionately less likely to be identified and evaluated for Part C. So to address this, we at the department formed a federal interagency work group to support state efforts in implementing an equitable and comprehensive system that identifies and evaluates infants and toddlers. So knowing the importance of interagency collaboration, multiple offices from HHS are part of the interagency work group, including Office of Early Childhood Development, Office of Head Start, Office of Child Care, Office of Planning, Research and Evaluation, Centers for Disease Control and Prevention, and Maternal and Child Health Bureau. This work group reviewed the current research and the program data and held listening sessions to better understand and provide technical assistance on how systems are being implemented across the country, what some of the key challenges might be, and successful practices for identifying and evaluating infants and toddlers. So together, we created a series of technical assistance implementation guides for Part C systems, as well as referral sources to Part C. And we've released 5 guides previously. Yes, count them, 5, that's a lot. And are releasing 2 more guides through this webinar that are focused on interagency collaboration and professional development to support more comprehensive child find systems. To release these implementation guides, I'm excited to be here with some of my colleagues, Treby Brown and Dita Leisner, from the Department of Health and Human Services, Maternal and Child Health Bureau. So at the federal level, we in the Office of Special Education Programs collaborate with our federal partners in HHS to make sure that infants and toddlers with disabilities and their families served in programs administered by HHS have the services and supports they need, because we know ongoing and well-coordinated state and local partnerships between IDEA Part C programs and early childhood, healthcare, and social service agencies have been shown to increase the number of children referred for early intervention services and promote more timely delivery of early intervention services, especially when there are well-qualified personnel working across these systems. We recognize that ensuring that infants and toddlers with disabilities and their families receive early intervention services is not just the responsibility of IDEA Part C, but of all early childhood programs and all health providers serving infants and toddlers. IDEA Part C, the Maternal, Infant, and Early Childhood Home Visiting Program, MICV, and the Early Hearing Detection and Intervention, EDI programs, and the personnel in these programs are extremely important parts of our early childhood system. And ensuring that all the infants and toddlers with disabilities and their families receive the services and supports they need to thrive, and that all these services are delivered by highly skilled personnel is the responsibility of all programs that serve infants and toddlers and their families. So as critical partners with IDEA Part C to support families in being connected to early intervention, Treby and Dina, I believe, Dina, you're going first. Can you talk about the program you administer and the importance of collaboration between your program and Part C and how that collaboration supports referral, identification, and service delivery?
Sure. Thanks so much. And it really is just such a pleasure to join you today from the Maternal Child Health Bureau, where our vision is an America where all mothers, children, and families thrive and reach their full potential, which we know means an America where children and families are flourishing from the start and are connected to the resources and services to support healthy development and family well-being, and that their development is on track in the earliest years and they're ready for school. And at the same time, that many children do not meet this criteria for school readiness when they enter kindergarten, and we have such an opportunity to work together. So the Maternal Infant Early Childhood Home Visiting, or MICV program, supports pregnant people and families with young children who live in communities that face greater risks and barriers to achieving positive maternal and child health outcomes. Families choose to participate in home visiting programs and partner with health, social service, and child development professionals to set and achieve goals that improve their health and well-being. The program is designed to strengthen families and communities and improve outcomes for young children, including focusing on improvements in school readiness, prevention of child injuries, child abuse, neglect, or maltreatment, improvements in coordination and referrals for other community resources and support, as well as improvements in maternal child health, reductions in crime or domestic violence, and even addressing family economic self-sufficiency. And so by design, the MICV program is a two-generation program that seeks to meet whole family needs. And those needs we know are at the very foundation of child development and lifelong health. And so home visitors and families develop strong relationships and trust through these regular home visits, which address families' needs by supporting healthy pregnancy practices, teaching positive parenting skills like reading, playing, praising good behaviors, conducting developmental and maternal depression screens, and connecting children and families to services when a need or a delay is identified, among other strategies. The MICV program prioritizes serving low-income families, pregnant women under 21, families with a history of child abuse or neglect, and other risk factors, and families with children who have developmental delays or disabilities. So here you can see that MICV can be a very valuable partner in Part C child find efforts as an important referral source, and vice versa. Both programs serve families with infants and toddlers. MICV programs conduct developmental screenings as part of what is expected to occur and may refer families to Part C for further evaluation and assessment, of course, if any need or concern is identified. And you can see that the other populations that I mentioned are families and children who are more likely to experience developmental delays, in addition to children with an already identified delays. And we know that families already served by Part C may benefit from that full family approach and added supports of home visiting. And another set of children who might be assessed through Part C evaluation processes or followed based on risk status, but not quite eligible for early intervention Part C, may benefit from home visiting as a preventive strategy. And MICV awardees are required to establish linkages and referral networks to other community resources and supports outside of home visiting. They are expected to, as I said, screen for child development, make timely referrals, and close that loop, make sure that those services were received if a delay is identified, and even required to implement signed written agreements with key state agencies, including the IDEA Part C lead agencies, to facilitate that coordination. And as was just shared, that well-coordinated state and local partnership between MICV and Part C programs can really have great benefit and can support smooth referral pathways for families and assure that families receive services that build off one another rather than duplicating similar content. In 2017, we partnered at an HHS to develop that joint statement titled Collaboration and Coordination of the Maternal, Infant, and Early Childhood Home Visiting Program and the Individuals with Disabilities Education Act Part C program. And the recommendations at a high level that were presented in that policy statement included setting a statewide vision for collaboration across early childhood partners, establishing shared or partnering state organizational and leadership structures, building on existing interagency advisory groups like the State Interagency Coordinating Council to explore and promote greater collaboration, developing centralized or coordinated intake and referral systems, developing policies and procedures on dual enrollment, identifying other opportunities for coordinated service delivery, exploring integrated data systems, and working on that cross-sector professional development. And we're really excited that we've recently been really continuing that partnership and trying to say, okay, we put out that statement. What is the status now of that McV and Part C collaboration? Where are there bright spots and gaps? And a forthcoming set of TA briefs that really reiterate a lot of the principles from that original policy statement and offer some examples of collaboration will be released later this fall. And we're really excited about that. And just one, two additional pieces of information. A well-functioning early childhood system reaches families early with universal preventive and more targeted and indicated supports and services and improves coordination. And that ultimately such a system brings partners together and promotes early childhood development and family well-being from the start. And we also support the Early Childhood Comprehensive Systems program, and really 20 states right now are working to advance strategic plans and really committed to this kind of work. They're currently also working on sustainability plan development, and so encourage you to make those connections. And we also support a program called the Transforming Pediatrics and Early Childhood Program that really is, enhancing what occurs in the health sector, that pediatric primary care is such an important access point for children and families to make those connections with Part C. So also encourage, partnerships with those particular set of awardees. There are 8 states. And then just that reminder of where the health system sits within that comprehensive early childhood system. So again, I know we can do so much more together and really appreciate the opportunity to be here.
Thank you so much, Tina. I greatly appreciate it. Treby, what do you have to share with us?
Thank you. It's always a pleasure to be with our OSEP colleagues. I work with Dina in the Maternal and Child Health Bureau, and I work specifically in the Division of Services for Children with Special Health Needs. And we are the key division for planning, development, coordination, implementation, and operation of an array of programs that address the unique needs of children and youth with special health care needs. And we also work really closely with our Division of State and Community Health, which administers the state Title V Maternal and Child Health Program, which supports programs for children and youth with special health care needs. And many have close connections with Part C programs. And so at MCHB for children with special health care needs, we are really guided by the definition that children and youth with special health care needs have or are at increased risk for having chronic physical, developmental, behavioral, or emotional conditions. So they may have conditions like asthma, sickle cell, epilepsy, anxiety, autism, and learning disorders, and they may require more specialized health and educational services to thrive, even though each child's needs may vary. And many of these children are children who would benefit from Part C services. We're also guided by the Blueprint for Change. So HRSA developed in partnership with families, and we'll put a link in the chat for this, the Blueprint for Change, which is a national framework for a system of services for children and youth with special health care needs, where they enjoy a full life and thrive in their community from childhood to adulthood. So we have a vision that we want every family to get what their child needs so they can play, go to school, and grow up to be a healthy adult. And we want parents and children to thrive too. And so one of the key elements of the blueprint is a call for systems and sectors to collaborate to ensure that policies are coordinated, effective, and developed equitably. And interagency collaboration is one mechanism. And one of the areas where we've really been working to encourage both collaboration at the federal level and the state level is between our Part C program and the HRSA Early Hearing Detection and Intervention program. So our EDDI program, the goal is to improve language acquisition for deaf and hard of hearing children up to age 3. And many of you work closely with your state EDDI programs, and you know that they work to ensure that newborns and infants are screened for hearing loss, diagnosed by 3 months, and enrolled in early intervention by 6 months. So referral to and enrollment in Part C programs is critical. But we look at EDDI as not just a series of steps, just limited to the 1, 3, 6. It's important to acknowledge EDDI as a system, and Part C is a really critical part of that system. And I also wanted to call attention to our EDDI legislation, which guides our work, because it also calls for coordination and collaboration across agencies. So HRSA is charged with developing and monitoring sort of state programs and systems. And CDC, we work with CDC EDDI programs on the data collection. And while it carves out specific duties for HRSA, it also aligns our efforts with Part C, since early intervention services and supports can be provided to eligible children through the IDEA Part C program, as you know. So those partnerships are just critical. And we've specifically been working hard with our OSEP colleagues and our CDC colleagues to model federal collaboration at the federal level. And recently, HRSA and OSEP and CDC released a joint letter highlighting the importance of working together. And this letter is a direct result of hearing from grantees about the need for collaboration and support at the federal level. And it really highlighted that to encourage state programs to develop coordinated systems of care, the importance of data sharing, and providing technical assistance. We know this is just a first step, but we're already hearing some good feedback from our state programs that have been has been very positive with reach outs from both programs. So we know this is a first step. We know that states will need further guidance and tools as they advance this work, but it's a concrete example of how we are committed to working together at the federal level and providing support to you as you implement your programs. Thanks.
Thank you very much, Treby and Dina. There is no doubt that we want to model at the federal level the partnership and the collaboration that we want to see at the state level. And it is such a pleasure to be able to reach across agencies and pick up the mantle and do this work for our children. So thank you very much. I greatly appreciate it. This improved interagency collaboration, we know it can have substantial positive impacts for infants and toddlers with disabilities and their families that sometimes might have been historically underserved by IDEA Part C. And this only happens if those strong partnerships are across not just Part C, early childhood programs, the healthcare system at the state level, and in local communities. So we have more fantastic panelists that we're going to hear from, speakers from 2 states that are going to be highlighting some of their partnerships and how they have implemented strategies that support collaborative processes and practices that connect families to the early intervention systems and support them in going through the referral process. They will also highlight for us how they have supported personnel in their systems to collaborate and ensure that they have the skills and knowledge to support referral and identification. I look forward to hearing about these partnerships in action from our 2 speakers, Lori Witterman from the Wisconsin Department of Health Services that will talk about Part C and EDDI collaboration, and Sarah Remington from the Rhode Island Department of Health who will talk about Part C and McVie collaboration. So, Lori and Sarah, uh, can you explain to us what programs you administer and how you have partnered with other programs and agencies to build collaborations to support child find efforts? How about Lori? Why don't you go first?
Thank you. Hello, everyone. Yes, I work at the Department of Health Services in Wisconsin, and I've worked in the Birth to Three program for over 40 years at various levels. Since coming to the state, we are in the Department of Health Services. The school districts are in another department. Child find, home visiting, early Head Start are in another department. So we do some cross department types of things. So I wanted to share just kind of in general the various agencies and programs that we work with to support child find, and then talk more specifically about the early hearing detection and intervention program. So we have, as I'm sure many of you do too, in Part C programs, have an interagency agreement with our Department of Public Instruction, and it addresses both child find and transition from the Birth to Three program into the school system at age 3. We, in addition, have a data sharing agreement with our state agency and each local school system, so that we can make referrals directly to the school system for children through our statewide database. We actually require in our state law that each county Birth to Three program in Wisconsin has an interagency agreement with each of their local school districts. At the state level, we meet on a quarterly basis to talk about child find, access, what's stopping certain populations. Most recently, we were talking about vision and hearing and children with those sensory needs. We also have our interagency coordinating council, also required for Part C programs. And we have vision and hearing and the schools and Head Start, but not home visiting on that ICC. But we talk about child find a lot and the data, how many referrals have come in, what's happening with those, etc. And they provide advice and guidance and suggestions to the department. We have developed what we call a referral form. It was originally developed for physicians, but anyone in the community who can find it on our website can use it. And it has a release automatically as a piece of that, so that it allows for the referral source and the Birth to Three program to automatically share information back and forth, of course, if it's signed by the parent or guardian. We also encourage local Birth to Three programs to have interagency agreements with public health, child protective services, home visiting, and the tribes. We have 11 different tribes in Wisconsin, in addition to other partners like AODA and substance abuse, etc. We have, every year we give a specific grant to the tribes in Wisconsin, the 11 tribes, and that money is to be used for child find activities to help tribal children connect up with the county Birth to Three program in their community. Regarding the home visiting program, we have an MOU that I understand is required by McVie. And it's more general about we're going to work together at the state level, we're going to partner, we're going to support each other. And then it outlines some basic areas in professional development, in child find and referral, in resources, etc. And then we have a work plan that is more detailed and has what steps we're going to work on this year to improve the practices and the relationship between the home visiting program and the Part C program, both at the state and the local level. Last but not least, early hearing detection and intervention. We have had a long-standing relationship with the Wisconsin Sound Beginnings. That's our early hearing detection and intervention program in Wisconsin for years. And so ever since I've been at the State Department, I have been the subject matter expert for vision and hearing, even though I know nothing about them, but that means I work with our specialists at the state level. And we meet at least once a month and have for years to talk about what needs to happen for children. And our goal is always to make services better for children who are deaf or hard of hearing. So several years ago, actually in 2010, we developed an MOU, Memorandum of Understanding, between the two programs about making an automatic referral from our audiologist database called WeTrack to our Birth to 3 program statewide database. So just like I said, we refer directly to the schools, the audiologists refer directly to the Birth to 3 program when they have diagnosed a hearing loss. And a child with any level of hearing loss is eligible for our program. Our ICC had a work group that came up with that's what we want as our eligibility criteria. So that has been in place since 2010. At the same time, when we were trying to figure out how could we share information without a release and how could we make this most beneficial to families, our Office of Legal Counsel determined that our Wisconsin Sound Beginnings program, being in the same department we are, so that is a key thing, is considered a participating partner, which by law, federal law, is considered an IFSP team member. And so we do include in our notification of rights regarding records to every parent that if their child has a hearing loss, that the Wisconsin Sound Beginning staff will be able to have access to their information in order to be an IFSP team member and support that child and family. If for some reason the family does not consent to that service, then they don't get any information. But that is given to them right away. And so, and our EDDI program actually has 3 staff for our whole state. We have 72 county programs, 3 staff that provide direct intervention, usually through consult or joint visiting, but are able to provide to support families of children who are deaf and hard of hearing. That is how we are currently promoting child find, utilizing our resources to try to get referrals as soon as possible.
Perfect. Thank you. Sarah, can you share?
Sure. So hi, everyone. I'm Sarah Remington, and I oversee our family visiting programs through the Rhode Island Department of Health. In Rhode Island, we like to be a little bit special and unique, so we have rebranded our home visiting programs to family visiting programs based on some feedback from some of the families that we were serving and some of the families that we were not serving and why they were not engaging with us. So you'll hear me say family visiting, but it's home visiting. At the Rhode Island Department of Health, we oversee 4 programs, 3 of which are funded through MCV and are evidence-based programs. But we also have a homegrown program, which is actually a child find program. It's called First Connections. And all 4 programs work really closely with our Part C coordinator and our early intervention staff. Like Lori mentioned, part of the MCV requirements are that we are supposed to have an MOU with our early intervention and Part C program. So that kind of lays the foundation for our work together. But we really do partner very closely with our, not only at the state level between our Part C coordinator and myself, but also we encourage our LIAs to work together, our implementing agencies. We don't have 72 counties like Lori has in Wisconsin. We have, I think, 5 in Rhode Island, and we only have 9 agencies implementing our 4 family visiting programs, of which 4 of those also provide early intervention services at their agency. So it does make it a little bit easier to collaborate and get to know each other. So I think one of the things that we think about best and how we partner with each other and supporting child find is, obviously, we have the MCV requirements to screen children at a certain age and offer resources when available to early intervention or other supportive services. But we've really focused a lot on how we put those requirements into practice, not just something that we're told to do or our staff or our family visitors are told to do. And it's really been something that we try to model from the top down. So the Part C coordinator and I talk all the time on a regular basis. We meet regularly. We co-chair a family visiting council together, a statewide family visiting council. And then we encourage our agencies to partner with each other at the local level. We employ a community health worker as part of our family visiting team. She's at our state's largest birthing hospital 5 days a week, talking to families that are about to go home with a newborn. So if they do have things anticipated like hearing loss or other concerns where we know that there's going to be an automatic referral to early intervention, she helps facilitate that referral even prior to hospital discharge. We've also created a shared referral form. So we have a no wrong door here approach in Rhode Island. So we can use the same screening form. A pediatrician or a provider can use the same screening form to make a referral to family visiting or early intervention. And our community health worker will facilitate that referral to desired place. And she will call the family first to make sure that they are being linked to the early intervention provider that they want to be linked to as well. I could talk a lot about what we do at the state level too, but it's also about how our staff partner together. So our family visitors and our early intervention workforce. One of the fun things that we're doing is we're planning a workforce celebration in early October, because we know this work is really hard. It is increasingly stressful. Families come with complex needs. I know in Rhode Island, we are seeing an increase in substance use disorder and substance exposed newborns. We don't have enough housing like many other places. And just the increased stress on families, it's impacting our workforce as well, many of whom are parents themselves and also facing similar stressors. So we are getting together and we are hosting an event, a fun day of learning with our early intervention workforce, our family visiting workforce, and also our early Head Start workforce to celebrate them, protect their time, clear their schedule for the day, and really get to spend some time in community with each other, because these are people that talk to each other all the time, but don't necessarily get to spend some shared learning time together or share some shared celebration time together. So we have a fun day planned for them. And this is going to be our 4th celebration that we are doing together. We find that it's the highlight of the year for many of our team members. And just to take away and acknowledge all their hard work and the stress that they are under. I will just say the last thing we do is we also have a workforce council that we are partnering on with early intervention and early Head Start, so that we are planning shared trainings together, so that people are hearing the same messaging from the same trainers. You know, we had an example recently where we were all using a different trainer on interpersonal and domestic violence. It didn't make sense. So we started to partner together so that we would, build those collaborations and everyone could learn together and also get to know each other a little bit more. So that person that you're calling to make an early intervention referral, you can actually put a face to a name. We do encourage our family visitors to invite the early intervention team or vice versa if they're both working with a shared family, to also not overwhelm the family. And that's been something pretty successful when the family wants us to do that.
Thank you. I was just thinking, and I wrote down that I love about how you're not just focused on the work, but the workforce.
Yeah.
And the celebration and making sure that the training is in place and that it's all in alignment. That makes a huge difference, a huge difference. Next question for the two of you. What's a strategy that programs should consider as they develop partnerships that support child find? And Sarah, since I'm looking at you, you can go first.
For us, we love our data. And so, with Big V, there's a lot of reporting requirements. And we take a look at our data by agency and by program at the evidence-based level. We also look at it for our homegrown program. And when we see trends and dips in screening or dips in referrals, we are not shy about going to the agencies or our family visiting programs and asking them what they need. And oftentimes it's more training and understanding the ASQs, or how to do a developmental screening, or how to talk to parents or caregivers about it. So this is where our partnership with our Part C coordinator and the other early intervention providers in Rhode Island is critical. We now have standing trainings that our Part C office offers. We are able to also do some targeted work together on referrals. So I think, like a lot of other places, we've had an early childhood workforce crisis. It's hard work and people are not lining up to do it, at least in our part of the state. So we've been able to really work with our Part C coordinator on understanding, wait lists for services, either on the family visiting end or the early intervention end, and how do we partner together to make sure that parents who might be on a waiting list feel supported while they might be waiting for services, but also how to have the conversation with families and let them know that, they're still important. Maybe there's some developmental activities that the family visitor can do while we're waiting for services. And it's really been about how we are messaging to families. It's not that one service is any more important than the other, but how we work together, especially when there might be times when one might not be so immediately available.
That makes complete and perfect sense. Lori, what are your thoughts?
The first thing that comes to my mind is the building of relationships. Of all of the different agencies and programs that we try to collaborate with over the years, the ones that last are the ones where you get to know the people in the other program personally. Not that they're your best friends, right? But that you know them well enough that you're comfortable with them, that there's this level of trust that if you accidentally share something, maybe I wasn't supposed to say that from my program, it's going to be confidential, and they're just going to help you think through that, work through that. So spending time together, it's the programs that we do meet with on a regular basis that we have better collaborations with. And I think the next step of that then is breaking down the barriers that stop either the programs or the families from being able to access those programs. For our EDDI program, the biggest barrier was, how are we going to get releases and how are we going to identify them and then let the EDDI program know we want you involved, but we don't have a release yet. And so that whole participating partner piece was one way for us to break down that barrier while still keeping families fully informed of what was going to happen before anything actually happened, right? Through our notification of rights regarding records. Another example is our home visiting program. We had staff on both sides that were like, well, the programs are different, but at the same time, they're both doing home visits. And we know that in early intervention, the more people saying to the family, you should do this and you should do this, and now the family has too many things to do. They cannot do it all, right? And so we have County Birth to 3 programs that are partnering with their home visiting program, and their home visitor is actually their primary home visitor. As a Part C program, we come in as a joint visitor or a consultant and support that person and the family and child in knowing what to do. But the family doesn't have to have 2 or 3 different visits every week. And it's that kind of relationship building where you can trust and go, if I share this with this other staff person, I know that they're going to support the family moving forward. I don't have to be the one to tell them, or I don't have to be the one, to be checking in. They're going to let me know what's going on. Right? They're going to let me know if it is working or it's not. So I think those key things are what help us really build relationships. And then I'm hearing a colleague of mine in my head. And remember, it is not about us. It is about the family. So what do we need to do to get this to work for the family? Right? And starting with Child Find. What do we need to do to help every family who might need these services, whichever one of these programs it is, figure out how to get there?
And honestly, isn't that why we're all here? Because we want to make sure that the children and the families get the services they need And I really like how you're thinking about it, not just from the perspective of what work needs to be done with the family, but from the family's perspective, how can we make this easy? And how can we make this something that they feel like they can do? And we're all supporting them, not a whole bunch of people discreetly coming in on their own, but working together. The professional unit, the providers, and the families, so that in service to the child, which is what really makes all the difference. So I really love that. I have another question for the two of you. I really think this can benefit everyone who is listening. What are the benefits you have seen in your collaboration with other programs and agencies? I think this is, it's a relatively simple question, but it is a big question which gets to the heart of how do we start putting together some of these puzzle pieces so that we can better serve our children. So, Lori, I'll let you start us off.
Oh, sure. On the hardest question. What are some of the benefits that we've seen? Well, like you said, I think there's some very obvious or simple answers and then more complex. So some of those simple ones are that we learn from each other what might be the best way to support a family, right? Because if the home visitor has already been going in for a year before the Part C program gets that referral and starts working, they can give us some insight into how to work with this family, what might be of most interest, what to stay away from, how to approach them, some of their culture in their family that we won't know because we're brand new to meeting this family. Huge, right? But also kind of simple, but we forget. We have more families, the more that we collaborate across programs and agencies, you have more families that know about all the various services and options available to them and their child. And so then they can pick what will fit them the best, which is, again, all of our favorite goals, right? There's also a benefit to, in our case, for most of our interactions and collaborations, is our providers. They not only build the relationship with the other program providers, but they learn from each other, right? And they learn about what does a child with this area, in this case, early hearing and detection, right? With a hearing loss, what do they need that I don't know already? Because I'm not the expert in it. So by partnering with the EDDI program, our staff gets supported, whether it's directly or indirectly through what we see modeled and shared during home visits. We look at our data together, not necessarily child level, but aggregate, and we're able to evaluate our programs and say, where is those gaps? What's missing? Why do we have this pot of families who are saying no to both of our programs? What's that all about, right? So by looking at our data together, we can monitor, we can evaluate, we can look for effectiveness. Yeah, I think those are probably my biggies. I'll pass it to Sarah.
Thanks, Lori. I would echo a lot of what you said in terms of the benefits of collaboration. Like I mentioned earlier, we try to model what we want our agencies to do with each other from the top down. I think one of the biggest benefits we've had too is we actually have a statewide parent caregiver advisory council that is not just only home visiting or family visiting, but is also early Head Start and early intervention together. And the benefits come out pretty easily when you start talking to the parents on that council, when they start talking about seamlessness and services and how much easier and nice it is when their service providers are all working together. And so those kind of benefits just radiate out. And when you're able to share those examples with your family visitors or your Part C staff, it just kind of becomes a no-brainer. Like, yes, we're not perfect at it and we have to keep working at it. But when you can just see relief in a family member or, the shoulders start to come down because there's been some joint talking together about, how well the child is doing and how we're going to continue to support your family. And it's a joint message. it's impactful on families. So I think that's the obvious benefit why we're all here. I'm also thinking though about the EDDI program. It's 5 feet away from me on the other side of the door, and the work that we've been able to do with them. We have a community health worker there who's done some amazing work, and she's supporting in families and engaging in, services related to hearing loss. But then she's also conversely making a lot of referrals to family visiting because she's in homes and she's seeing some of the basic needs or some of the other social supports that a family might need. And so we've had a lot of wonderful partnerships together in serving families with hearing loss, and then also connecting them to early intervention services because of those relationships. We have trust in each other. If she says this family needs something now, we believe her, and we make sure that an agency is out there to see the family within 24 to 48 hours. So it's those kinds of relationships, and that trust is multi-level. And so I think that's been one of the biggest benefits we've seen through our partnerships together.
I love that. Actually, a question came in that I would like for the two of you to ponder and give us your expertise on, because we do have an additional minute. So have either one of you been able to identify unique underserved populations within your community who may fall outside of the scope of how your programs normally operate and fall through the cracks? And if so, how have your agencies adapted to those challenges? So whichever one of you just wants to jump in first.
I'm not sure if this is a population that would fall through the cracks. But we have recently, or not recently, but we've been more intentional about our work with our peer recovery specialists. And we know that families with substance use disorder might be some of the hardest families to engage. And children here in Rhode Island some of the children are categorically eligible for early intervention services. But we know when that child gets discharged from a hospital, there's so much going on in that child and that family's life. Certain services they might engage with, certain services they might not. And it's really been a journey with the peer recovery specialists, our family visitors, and then coordinating with Part C and early intervention to make sure that that family is connected to what they need, but also doesn't feel overwhelmed by it. So maybe not a population that's falling through the cracks, but one that could very easily on an individual basis.
Well, honestly, you know what? I think that's the perfect answer, because what you're saying is that you lean on the collaboration and the relationships and the partnerships that you've already developed to kind of problem solve and figure out what this could look like in service to the family. So I think that's the perfect answer. Lori, do you have anything you want to add to that?
No, I think, well, yes, in that I think the population that we've identified, there's actually two of them. One is our CAPTA referrals, our Child Abuse Prevention Treatment Act referrals, that those children have to be referred to the Part C program. However, we're not always able to find them eligible when they are referred. And so what we're learning through our connection with our school systems are that they're 4 or 5 years old, they're starting to show. And so that's a population that we have just recently started up a more regular meeting with our CPS, Child Protective Services staff, to talk about what is that all about? What else could we do? Looking at our tools for evaluation, et cetera. And the other population is those children affected by substance abuse. And we, in Wisconsin, we do have a third way to be eligible, the 25%, the diagnosed condition, or atypical. And so there are local birth to 3 programs that are using that eligibility criteria in these cases sometimes. But I think it's one of those where I think it's an aha to me as you ask that question, that I think we need to work more with our AODA substance abuse partners to find out, what are we looking at? What else do we need to know about these children in order to make sure that they aren't falling through the cracks?
Perfect. Thank you. so much. I want to thank all of the presenters on today's webinar. This has been extremely thought-provoking, I think extremely helpful for everyone that has been on listening. I made a couple notes that this is just a reminder once again that we cannot effectively operate in a silo. There is no way we can do this work if we are not reaching out to all of our partners. Some of the usual suspects, sometimes the unusual suspects, depending on where you are. But just think about whatever your role is, wherever you are, who else might be an interested party that can assist that might not be someone you are speaking to on a regular basis. I also made a note about intentionality and about how the intentionality is required for effective partnership and collaboration. It doesn't just happen by chance, and that it has to be systematized, right? So it has to go beyond personalities and people who like each other wanting to talk to each other on a regular basis. It has to be something that is woven into the fabric of the system in order for it to succeed and in order for it to last. So just wanted to share those couple things that occurred to me. A lot of information has been dropped into the chat in the way of resources. So you can access the resource guides and the webinars on the guides that have been released through one of the links that has been dropped into the chat. You'll be getting information in the next handful of days about this recording, so you'll have access to it. You'll know where it is. And I encourage everyone to review the guides, consider how you can work with your partners to enhance your referral and your identification systems, and how to support personnel who work within those systems so that they can develop the competencies to collaborate. Because the more we support the personnel, the more likely that we are to retain them. And last thing is that you will be getting a survey for the webinar. Please, please, please take a moment and fill out the survey. It informs our future work and how we do things and how we roll out information and share it with you. And so we would greatly appreciate you taking a few moments to complete the survey. So that ends our webinar today. I want to thank you once again for your time and for your energy and for coming and all the reactions that I saw popping in. We appreciate you. We appreciate your work, and I want everyone to have a good day, evening, and rest of the week. Be safe. Thank you.